Today we will discuss congenital adrenal hyperplasia, which is an inborn error of metabolism due to some enzyme deficiency. The learning objectives of this lecture are some basic concepts about congenital adrenal hyperplasia and what is the pathogenesis. How these cases present clinically and how we differentiate in the different forms. Then what type of the lab test can be useful for the diagnosis of congenital adrenal hyperplasia. Then how these tests are interpreted and used for the proper diagnosis. It represents a group of the autosomal recessive inherited metabolic disorders, and each is characterized by deficiency or total lack of a particular enzyme involved in the synthesis of adrenal cortical steroids. Steroidogenesis is then channeled into different other pathways. Simultaneously, deficiency of the cortisol results in the increased secretion of ACTH, resulting in adrenal hyperplasia. That's why this is the misnomer. In this case, this is basically hyperplasia due to the cortisol deficiency and leading to the excess production of the ACTH, causing the adrenal gland to work more, and then hyperplasia occurs. There are about 5 major enzyme deficiencies which are clinically important. The most important when 21 hydroxylase, 11 beta hydroxylase, 17 alpha hydroxylase, and 3 beta hydroxysteroid dehydrogenase, then 2022 desmolase deficiency. The occurrence of these in the population is different, but the more important are these two. 90% cases, rather more than 90% cases of congenital adrenal hyperplasia are due to 21 hydroxylase deficiency, which may be partly deficient, which may be fully deficient, depending on the mutation, depending on the sequence of the gene. Now, first of all, this steroidogenesis, this pathway should be kept in mind. This is the basic substance which is required for the synthesis of the steroid hormone. After the side chain cleavage, this is converted to the pregnenolone. Focus on these three, that if we go for these layers which we studied in the last lecture about the glomerulosa, fasciculata, and reticularis, then aldosterone, cortisol, and sex steroids like testosterone, these are the end products. These end products are required for the proper metabolism and proper working of these hormones on different tissues. If these are the which are shown by these numbers, these are the enzymes which are present for the synthesis and on action of these substances to produce further molecules. In this particular case, if we consider this one, 17-hydroxyprogesterone, if 21-hydroxylase is deficient, what will happen? These two will not be formed. Then there will be overproduction of this one, and this pathway will be converted towards this side. So there will be increased production of these substances leading to the virilization. So these are not produced, cortisol is not produced, and then aldosterone is not there. So deficiency of these hormones can cause some other symptoms which may be helpful in the diagnosis of the congenital adrenal hyperplasia. This is the point where we have to focus. So this is the square in which All other elements are deficient, but these are produced in more number, and because of the 21 hydroxylase deficiency, first product which will be more in concentration, which can be diagnosed by the concentration of these one, is the 17 hydroxyprogesterone, which is measured as the first line or even in the newborn screening for the diagnosis of the early diagnosis of the neonate. This enzyme should be kept in mind. Now, next is 21 hydroxylase deficiency. Impairs the synthesis of both cortisol and aldosterone. The resultant decrease in feedback inhibition causes increased secretion of the ACTH, resulting ultimately in adrenal hyperplasia and increased synthesis of testosterone. The sites of the action of 11, 17, and 21, they are circled and the word block is showing over there, and these will not be produced, and this will be increased in number. This is the simple thing to understand, that the block at this stage will lead to the overproduction of the metabolites behind this one. Adrenogenital syndrome or congenital adrenal hyperplasia is characterized by high levels of the sex steroids. There are about at least 8 distinct clinical syndromes are recognized, but the majority of the cases are attributed to the 21 hydroxylase deficiency leading to CAH. It is an autosomal recessive condition. It is a rare disorder occurring about in 1 in 15,000 or 1 in 10,000, but we do see the cases of CAH. There are 3 syndromes related with congenital adrenal hyperplasia. The first one is the salt wasting. It is the most severe and accounts for 70% of the classic 21 hydroxylase deficiency cases, and there is complete deficiency of the enzyme in this that leads to very low levels of the aldosterone and cortisol. Because minimal aldosterone is created, salt is lost, leading to hyponatremia, hyperkalemia, and increased plasma renin. In this case, that's why it is called salt wasting. Second form is the simple virilizing adrenogenital syndrome. In this form, cortisol synthesis is impaired and leads to the increased androgen activity, but there is sufficient enzyme activity to maintain normal or only slightly decreased aldosterone production. This thing has to be remembered. In this particular type of the category of congenital adrenal hyperplasia, the aldosterone production is slightly decreased, or it may be a little bit normal. The third form is the non-classical. The 21 hydroxylase deficiency, less severe form of the disorder. About 20 to 50% of the 21 hydroxylase activity is present as compared to 0 to 5% in this particular case. And in this, about 20 to 50% activity is present. Salt wasting is absent in this one because aldosterone and cortisol levels are normal. However, adrenal androgen levels are slightly elevated, which result in mild androgen excess in childhood or adulthood. These are the 3 forms, and we have to differentiate clinically for proper diagnosis between these forms, which we will be discussing in the next slides. So, what happens with the male pseudo hermaphrodite include 21 alpha hydroxylase and to a lesser extent 11 beta hydroxylase. With female pseudo hermaphrodite includes 17 alpha hydroxylase, 1720 lyase, 3 beta hydroxysteroid dehydrogenase, and cholesterol 2022 desmodase. These are the enzymes which are involved in this particular category in which female pseudohermaphrodite is the main case. Congenital adrenal hyperplasia forms which are associated with hypertension, and the last slide we discussed include 17 alpha hydroxylase and 11 beta hydroxylase deficiency. This one is associated with hypertension. Now, the important thing is sign and symptoms. Mainly these are due to the production of the male sex hormones before birth and in childhood and in adulthood. In male, there will be external enlarged external genitalia. In female, if it is before birth, then enlarged clitoris resembling labia resembling that are male external genitalia. In childhood, premature sexual development, enlarged penis, appearance of the pubic hair, early union epiphysis, which is called precocious pseudopuberty, precocious development of the secondary sex characters without testicular growth, and in childhood, in the female case, no development of the female sexual characters, no enlargement of the breast, deepening of the voice, muscular growth because of the production of the sex steroids like testosterone and DHEA. Now, these two things has to be differentiated. The symptoms are a little bit different. In adulthood, the male may be having increased muscular power and increased sexual desire. And in female, there will be hirsutism, and there will be pattern of the male hair distribution, frontal balding and deepening of the voice, amenorrhea, atrophy of the uterus and breast, and clitoris hypertrophy. These are the signs and symptoms which are present, which may be present at the pubertal stage. These may be present at the prepubertal stage, and they may be present when the child is born. Now, how we diagnose the case? All cases of CH, the adrenals are bilaterally hyperplastic, sometimes increasing to 10 to 15 times their normal weights because of the sustained elevation in the ACTH. There are three types of the categories for the diagnostic evaluation: blood tests, imaging studies, karyotyping, and the genetic analysis. If you look for the diagnosis, these are the hormones which are important, and you have to must keep in mind that this is the baseline test. That is 17 hydroxyprogesterone, it is increased. Aldosterone is decreased, cortisol is decreased, as we saw in the pathway in that algorithm. Then testosterone is increased because all the things are due to the increased 17 hydroxyprogesterone. It is converted towards the increased production of the testosterone. Then DHEA and androstenedione, they are also increased. Renin and the ACTH levels are also increased. In electrolytes, there is hyponatremia. And in the case of the potassium, there is hyperkalemia. These 2 points are important in attempting the MCQ, and particularly, so this is also important to keep in mind that sex steroids are increased. These are the hormones which are used for the diagnosis of the CH. Then genetic analysis that depends on 21 hydroxylase gene analysis, CYP21A2. That may be for the panel mutation depending on the availability of the facilities, then sequencing, and there may be documentation of some deletions. These are the few things which can be done for the proper genetic analysis of 21 hydroxylase. Then karyotyping is important to see for the XX and XY and other deletions if they are present along with this one. Then carrier screening is also very important to identify either it's in the families or a child is going to be having something in the next birth. Then newborn screening, which is not done over here in our country. The 17-hydroxyprogesterone is used as a routine test when the child is born, and it is done along with the other inherited metabolic disorders in the newborn screening, in which 5 to 7 disorders are included. Now we see the different forms of the deficiency. Phenotype, age at the diagnosis, genitalia, 21 hydroxylase. If you see at the age of the newborn to 6 months, this is classical salt wasting. The simple virilizing, newborn to 2 years. Non-classical, child to adult. These are the age brackets in which these tend to occur. Then genitalia, in male it may be normal, in female there may be ambiguous genitalia. Same is the case over here, but in non-classical, female is not having the ambiguous genital, but they are virilized, having the hair pattern and virilization and hirsutism, all the characters which we saw in the last slide, these are present in the non-classical. The activity of the 21 hydroxylase, they may be 0 or 1 or up to 5%, but it is up to 1 to 5% in simple virilizing and 20 to 50%. That's why it is less severe. Same which we discussed in the last slide, 17 hydroxy, it's more than nanomole, more than 5,000. It's 2,500 to 5,000. It is 500 to 2,500. It shows the severity because of the deficient activity of the enzyme. Then aldosterone reduced. It may be normal in simple virilizing. It may be normal in non-classical. So is the case with the cortisol. It may be normal in non-classical. Renin is increased. It is normal in that one. Then testosterone are increased in all the three, but it may be a little bit normal or it may be increased. Mostly it is increased in this category. Now this table is important for remembering the characteristics of the three forms of the congenital adrenal hyperplasia due to 21 hydroxylase deficiency. By this having in mind, you can attempt different questions and scenarios which will be asked in the examination. Now, 5 key points to remember regarding the CH. Children with the 21 hydroxylase deficiency have varying degrees of androgen excess, and about 70% have a salt wasting form caused by aldosterone deficiency. Second is, in females, androgen excess usually manifests at birth with ambiguous genitalia, that is clitoral enlargement, fusion of the labia majora, a urogenital sinus rather than the distinct urethral and vaginal openings. Later in life, they may have hirsutism, oligomenorrhea, and acne. Now, in females, it will present like this. Then the third point, in the male, androgen excess may not be apparent or may manifest in childhood with increased growth velocity and early sign of puberty. Then in both sexes, salt wasting causes hyponatremia and hyperkalemia. This is to be kept in mind. In salt wasting, there will be loss of the sodium level and there will be increased level of the potassium. Diagnosis is done by the steroid hormone levels and sometimes ACTH stimulation or genotyping. This is normally not required. It can be done if there is borderline cases, but genotyping can be done for further evaluation. Now, an excess-free infant is found to have external male genitalia. I'm just showing you this, what type of the scenario can be in the exam. And internal female genitalia. Physical examination reveals decreased blood pressure, while lab examination reveals sodium level 132. Now, in the next lectures, we will discuss that you have to remember some important parameters of clinical chemistry and their normal values for proper evaluation. Sometimes the values are not given. Here you cannot be sure that if you don't remember the value, either it is less or 135 is the lowest upper limit in which you, from where the borderline reference range starts. No, it is 32. Additionally, bilateral adrenocortical hyperplasia is present. Finding in this infant are most likely the result of the deficiency of a. These are the enzymes given. What it can be. Anyone can guess and keep in mind. It is the 21 hydroxylase because all the features, all the key points, hypophilia, this level hyponatremia, and then female genitalia, then decreased blood pressure. These are all in favor of this 21 hydroxylase. It's a very simple question. Which of the following will not be the finding in a patient with a CH? Increased ACTH. It will be there surely because of the non-availability of the cortisol. It will continue to be secreted by, then it will to act on the adrenal to produce more cortisol. So it will be there. Bilateral adrenal hyperplasia will be there as the name suggests of the CH. Then variable production of the mineralocorticoids, that will be variable aldosterone and other. Then decreased androgen production, it means and decreased cortisol level. This is definite. The answer would be then very simple, straightforward. If you follow that table or that chart and keep in mind, then you can very easily attempt the question. The answer will be decreased androgen production. A physical examination of a neonate by a pediatrician shows peculiar genitalia shown in the figure. Cytogenetic studies reveal 46XS karyotype. Lab studies will most likely reveal a deficiency of which of the enzymes? That is the clear-cut answer of this one. That is the 21 hydroxy because there is no any other thing which is going in favor of this one. Which of the following is not the characteristic feature of 21 beta hydroxylase deficiency? Now, what can be the answer? Hyperkalemia, hyponatremia, low serum. This is the same question which was asked in the previous two slides. Then it comes to the low serum because all these will be increased and all these are the features of the due to the deficiency of the aldosterone and cortisol. So low serum DHEA is not the answer because it will be increased in number. Thank you very much.